lesion. For example, if you have a patient with chronic pancreatitis and you want to exclude pancreatic cancer, a lot of time we just don't get an answer from EUS FNA. All you're going to get is chronic pancreatitis, and it's very difficult to differentiate pancreatic cancer from chronic pancreatitis. For the purpose of my lectures today, I'm actually going to focus on the aspiration techniques, needle selection, and tissue handling and processing. What are the technique choice? Aspiration techniques, people talk about fanning technique. We'll talk about fanning technique in a little bit. People ask if you should do the fanning technique throughout the lesion, or you should pick the center of the lesion, or just peripheral area. We don't know. Speed of the needle throw. So when you do the FNA, you might see a lot of people do it very quickly, or some people do it very slowly. People talk about the speed of needle throw. No one really studies the speed per se, but there have been some techniques proposed by the Japanese, including the door knocking technique and woodpecker technique. The differences between these two techniques is that for door knocking technique, what they propose we do is to advance the needle in quickly, and then to allow the needle to hit the stopper, creating a knocking sound. And we can actually take a look at it when we do the hands-on session, and then slowly pull back the needle during the stroke. So you basically jab it in real quickly, you hit the stopper with the handle, and you slowly pull back. The woodpecker technique, that's good for a small lesion, like less than 1 centimeter lesion. Basically, you're moving the needle finely in and rapidly within the lesion, sort of like, quick jabbing in and out like that, okay? But because the lesion is very small, so you sometimes you can't do a long stroke. You can only do like a fine and small strokes. Now, people talk about number of to and fro within one pass. No one really looked into this though, but there have been some study that briefly look into it. Number of passes and the use of silence. So these are the main things people talk about when we address aspiration technique. What about suction? We used to use standard dry suction technique using a 10 to 20 negative syringe. 20 is considered high pressure, 10 is low pressure, that's called dry suction or standard suction. Wet suction has been proposed using saline. You basically prompt the needle with saline and you do the aspiration that way. Some people don't use suction at all. What about stylet? Stylet, there's been a new technique, a relatively new technique called slow pull technique, which is the way you slowly pull back the stylet. It's called slow pull. So basically, when it comes down to suction, what you need to know is standard negative suction or dry suction, wet suction, slow pull, and no suction. I have some data comparing these different techniques for you. Last but not least, very important as well, tissue handling and processing. You might be familiar with rapid on-site evaluation of rows. That's when you have a pathologist in room with you and they take a look at the slides for you as you're doing the procedure. For those who don't have rows, people talk about MOS. Okay, MOS is the macroscopic on-site evaluation. So basically, you just take a look at the tissue yourself. The other thing that people talk about is doing cytology alone, which is FNA, versus doing histology by using a needle biopsy or a cell block preparation, and we'll talk about it a little bit. Okay, so what you need to know is rows, MOS, cytology, and histology. Needle selection. Needle selection is very important. FNA has been used and proposed for a long time. We have different sizes of needle, but just recently, a newly designed needle, which is called biopsy needle or FNB needle, has been released, and we have data comparing FNA and FNB. A lot of people moving towards FNB, but is that really necessary? We'll talk about it. Now let's start out with technique choices. What's the evidence for different techniques? This is fanning techniques. If you look at that cartoon diagram right there, the first group proposing fanning technique is Baradarajilu. So basically what they propose we do when we do fanning technique is to divide the lesion into 4 different quadrants. And you basically aim your needle trajectory to these 4 different quadrants, but you would do 1 quadrant at a time. And each quadrant you would push the needle in and out basically to and fro 4 times. So 4 times each quadrant, total of 16. Okay, that's the conventional or original description of fanning technique. So this study is an RCT comparing standard technique versus fanning technique. As you can see here with standard technique, after first pass, you get the diagnostic accuracy of about 57% compared to 85% if you were to do fanning technique. And that's no needle dysfunction. And because of this study, fanning technique has been implemented into our daily practice. What about number of passes? Many studies have been looking at the number of passes using mainly 22 gauge needle, different kinds of lesions, but majority of them is pancreatic masses. And as it turns out, they show that between 3 to 4 passes, that's pretty much the optimal number of passes. So 3 seems to be a magic number here. What about the use of stylet? There are 4 RCTs comparing the use of stylets. These studies have been done mainly on pancreatic and lymph nodes. The majority of the needles being used is 22 gauge needle. Some of these use 25. And what the data show is that there is really no significant difference when it comes down to tissue adequacy and quality. However, the key question, which is the diagnostic accuracy, has not been assessed in any of these RCT. So what we learned from this is that use or not using stylet doesn't seem to matter when it comes down to diagnostic adequacy and quality. What about suction? If you have done EUS for enough, the story of suction in EUS is that we started off using dry suction, 20 cc's of negative suction, and then over the past 5 years, people say suction is no use. Mainly, it's going to give you more blood. Then we stopped using suction. We started doing slow pull technique. But the Japanese are the people who insist of doing suction. So what the study shows really among these RCTs, the use of suction, and what I mean by suction is 10 or 20 cc's of negative suction. What it shows is that the suction actually increases sensitivity and diagnostic accuracy. However, it also increases blood contamination in some of the studies. So the story of suction now turns out to be that the suction is actually helpful, but if you have any lesions that very hypervascular or tend to bleed very easily, you might want to avoid using suction. So in my own practice is that I start off with no suction, and if I don't get any tissue at all, then I would add suction. Okay. What about wet suction? Wet suction is a new way of doing the suction. Not a whole lot of people using it. It seems to be a little bit complex when you use it. Basically, what you do with wet suction is that you add the column of needle with saline, and instead of using negative pressure, you just use that column of fluid to create a suction. Only one RCT, but a big RCT. Basically, again, the diagnostic accuracy was not assessed, but in terms of tissue adequacy and cellularity, it seems that the wet suction increases the rate of tissue adequacy. Not a whole lot of people using it, as I said before, but I think it's something that you might want to consider if you want to increase your yield. What about slow pull technique? For those of you not familiar with slow pull technique, basically what we do with slow pull technique is that we slowly withdraw the stylet. If you remember what the biopsy or aspiration needle looks like, there is a stylet. You basically slowly pull the stylet as you are doing your FNA. There's one RCT that has been presented years ago. It's only in abstract form. The original article hasn't come out yet. But there's one large retrospective study looking at the utility of slow pull technique in a 25 gauge needle, and it seems like it provides less blood contamination and increases yield in pancreatic masses. So a lot of people are using slow pull technique right now. So just to summarize in terms of recommended techniques, fanning technique is definitely recommended with good evidence. Number of passes 3 to 4 without rows, 2 to 3 with F&B needle without rows. The use of stylet, really no difference, is your preference. What about suction? Standard suction still has a row. In terms of wet suction or slow pull or hybrid or no suction, is really up to endoscopper's preference. Okay, so the ones with solid evidence would be the fanning and the number of passes and the suction. What about needle choices? There are different sizes of needle, 25, 22, 19. The lower the number, the larger the size of the needle. So 25 would be the smallest size of needle. The differences between the needles is that if you have a larger needle, like 19, you're going to get more sample. When you get more blood contamination, it's more difficult to use because it's not very flexible. When you want to go and get a tissue sample from pancreatic head or uncinate, the larger needle is going to be more difficult. The smaller will be easier. If you want to puncture small lesions, small size of needle is probably easier. Vascular lesion, again, smaller size needle may be safer. So there are some, pros and cons in terms of different size of the needle. What about the newly designed needles? So what happens with the FNA needle is that a standard FNA needle, you only have a hole at the tip of the needle. But with the newly designed needles, you have a side hole right there, which is called side port. Or you have this, which is char core. The tip of the needle is different, allowing you to get more tissue. You also have biopsy forceps, and this is a Francine needle, which is the design in such a way that you get more tissue. So these needles will allow you to get this kind of specimen instead of like a smush of blood, and you get more histology compared to cytology. And this type of needle is called fine needle biopsy or FNB. So from now on, you're going to hear FNAB, or a lot of people say EUS guided tissue acquisition. The tissue acquisition by EUS is no longer limited to FNA. Okay. A lot of people is moving towards FNB. Now we believe that FNB may be better. Is it true? There have been 4 meta-analysis comparing FNA and FNB. Most of the studies were done with pro-core needle, and surprisingly, as it turns out, when you look at the diagnostic accuracy, there's no differences between FNA and FNB. But if you look at other outcomes, for example, number of passes, FNB seems to be better. For core tissue, FNB is definitely better. Again, fewer passes, better tissue adequacy. Those studies were done with ProCore. Our group has done a study using a different type of biopsy needle, which is called a acquired needle. And we pretty much see the same thing, that you get lesser passes, number of passes, and you get better core tissue. But when it comes down to diagnostic accuracy, it's pretty much the same as FNA. If you add histology preparation to the samples you obtain from FNA, which I'll show you in a second. So just to summarize the comparison between FNA and FNB, FNB seems to be superior in terms of tissue adequacy, and maybe it's better in pancreatic. There's some data show that FNB may be better in certain circumstances like pancreatic mass, but overall, if you look at overall data, it seems that the diagnostic accuracy is comparable between FNA and FNB. Safety is the same. Cost really depends on where you practice. There are different types of FNB needles, but most FNB study were done in Procore. But right now, we're doing more of the studies in different types of biopsy needle. Besides from type of the needle, the locations also influences needle selection. What I mean by that is that if you do transesophageal FNA or FNB, your scope position is straight, so your sensitivity and your yield is going to be very good, more than 95%. Whereas if you were to do the biopsy from the transduodenal, your scope position is going to bend a lot. So with that, your sensitivity may drop to about 80 to 85%. So the needle selection is going to be very important here, because when the scope is in this position, you can pretty much use any size of needle and it would work. But when the scope is in that position, the bigger size, the less flexibility, and the more difficult it's going to get. Okay, so with that kind of scope position, we tend to do a 22 or 25 gauge needle. So again, the same group, Ben has proposed an algorithm for efficient FNA and needle selection. So what it is that if you do transduodenal, they propose using 25 gauge. Transgastric or transrectal, 22 or 25, doesn't matter. Whenever you need core biopsy, for example, if you do lymphoma, if you need core biopsy, or if you do subcutaneous lesion, you may want to consider using 19, and that's for diagnostic purposes. But for interventional procedure, which we won't touch on today, you would only need to do 90 gauge needle. The smaller size gauge needle won't work well for therapeutic procedures. Last but not least, tissue processing. I introduced to you Rose, Mohs, cytology, and histology. So traditionally, Rose had the biggest impact thing to increase the diagnostic yield. That's the old data. But just recently, there have been some conflicting data as to whether Rose would affect FNA results. And the reason I'm saying that is because as you do more FNA, as the study comes out more from large volume center, we found that Rose doesn't really affect the results of FNA. It's in the sonographer experience that really affects the yield. Okay. So what we do when we get more experience is that we will train ourselves to do Mohs, which is macroscopic on-site evaluation. We would add additional tissue processing, which is cell block preparation to create histology examination. We use FNB needle to get core tissue. With that, it might be able to replace Rose. So here's what the tissue looks like. When you use a biopsy needle, you get this huge core tissue, really long. And Mohs is when you actually examine the tissue macroscopically. And whenever you see tissue length of more than 4 millimeters, like this one, I think is about 2 centimeters. That's the indicative of tissue adequacy. So there is an ongoing study right now, almost finished, to assess the role of Mohs in the absence of Rose. Okay, I can tell you that the preliminary data, it doesn't seem to Mohs doesn't seem to change much of the diagnostic accuracy in regards to presence of Rose. So we'll wait and see what the final results show. Anyway, this slide basically shows you how to prepare your sample for cell block. So basically, when you get your tissue sample, you put it on a slide, you smear, you send it for cytology, and the rest of the tissue you can put it into a 10% formalin for histology. So what they do with this tissue that you put in formalin, they're actually going to centrifuge it down, and they will remove the supernatant, and then they would get the pellet, and they would process the pellet with histology. And with that, If you do cytology in combination with cell block, basically you improve the diagnostic accuracy with clinical significance. So I'd like to encourage you to basically try to do all the measures to improve the yield of EUS FNA. Here's the ESG guidelines on technical aspects of EUS FNA-B. Basically, in terms of needle selection, 25 or 22 gauge aspiration or biopsy needle are equally recommended at this time. Whenever the primary aim is to obtain core tissue, then you may consider using a 19 FNA needle or FNB needle or 22 FNB needle. So here's the current recommendations, but again, everything is individualized. Like for example, for myself, right now I only use FNB needle. I don't use FNA needle anymore, except for the cyst or something that's really big that I don't need a whole lot of tissue. And again, cell block or histology preparation has been recommended in addition to cytology alone. So to conclude, I think the needle selection, different techniques, and tissue processing, these are the three key elements to improve your tissue acquisition yield by EUS. With that, I'd like to thank you for your attention.